Hi, this is Dr. Shrey Malik. I'm the oral maxillofacial surgeon representing the Maxillofacial Institute of Implantology. And we start out with radiographic evaluation. And the reason I picked up this topic first is because this is a tool we're going to use again and again when we're going to talk about anatomy, we're going to talk about even type of bones, even obviously during the surgical protocol lecture. So this will come again and again. It's better to master this because I will use this tool to give us better understanding how three-dimension object look like two-dimension, because in most of our cases we have PAs and a panoramic, and it's hard to visualize 3D images with the 2D images that we get with PA and pan. And to even make it more complicated, when it comes to PA and pan, they're not just 3D images. They're 3D images that have curvature to it. So you're taking, for example, mandible that has a nice curvature, horseshoe type look, and you have to see it in 2D and flat. So, we can't change that. But what we can do, unless we buy a CT scan machine, is try to understand radiograph and how we can, in our mind, interpret that 2D image into 3D images. And later on, when we talk about anatomy, I want you to also fully understand the concept of cone beam CT scan. So when we're going to start talking about cone beam CT scan, how to read it, how to manipulate it, and have a nice intellectual conversation with the surgeon if you're referring outside, or if you're obviously doing your own implant. So before I start, let's talk about radiation dose, because as you know, it always comes up. Your patient's like, well, I just went to this doctor and he took the whole little series of these little x-rays and there were so many of them. Now you want me to get a CT scan done. Is it safe? Well, there's some nice articles out there that kind of breaks it down relative to each other, so you can tell your person with exact numbers. And it wouldn't even hurt to have some of these numbers, as part of your consent, or before patient get their PAs or PANs, so you educated them and it's right there. So just to give us some type of references, a flight from New York, you can tell your patients, to Tokyo exposed the total body of 200. What 200, which is the dose we're using, is the radiation dose. Xavier's radiation absorbed dose is how much radiation is absorbed. So this is a standard unit that we're going to use, and we're going to compare it to give an idea how much radiation each of these modes have, the PA, PAN, and whatnot. So like I said, a patient has an idea that if they're flying from New York to Tokyo, the total body radiation would be about 200. When they go to a hospital, or whenever they have a chest x-ray, it's about half that, 1/4 to half that, so from 50 to 100. Everything is radioactive. We are radioactive. You're sitting next to a tree that's being radioactive. Even something like everyday banana has a radioactive give. So that's 0.1. Obviously, when you look at that 0.1, you can see how insignificant it is compared to a chest X-ray or the flight we talked about. A large view cone beam CT scan is 90 to 100. That's important. The whole large view CT scan, basically the maxillofacial part of it, is about as equivalent of getting a single chest X-ray. That tells you how safe the cone beam CTs are. And small view, because I know a lot of doctors have actually small view CT scan, that's only 10 compared. And that's extremely, you can see how much low radiation dosage that would be. A panoramic or lateral ceph is about 10. So a small view cone beam CT scan is equivalent to a single panoramic X-ray. An intraoral single PA is less than 8. So a small field view cone beam is equivalent of a single PA. That's pretty impressive. Now, compare this to a medical CT, non-cone beam CTs. The radiation dose is 15,000. And here you can see, when patient, I already got a CT from my doctor because I had headaches and whatnot, or, well, tell them, look at the difference. The one we're going to do in our office about 100, and what they already have in our medical office would be about 15,000. And there's not much that's statistically making any difference, especially when studies show that an effective dose of more than 10,000 can have a risk of only 0.056% chance of developing cancer or any other health issues. So even at 10,000, the chances are less than half of 1%. And we're not even being close when we're doing even a full view CT scan or a small view CT scan. So make that patient feel comfortable, and you yourself, that not just that it's the CT scan is an excellent model to have a good 3D dimension of the area you're working on your patient, but it's also relatively very safe compared to medical CT scan, and compared to, if you really think about it, panoramic and PA, especially with the type of information you're going to get from a CT scan. So when we talk about radiographic evaluation, in my mind, I've broken down to in 3 phases. I'm going to use radiograph for pre-surgical implant image to have a good idea of what my anatomy is, what my canvas is that I'm working on, how far am I from those critical anatomical structures like the nerve or the sinus. So the radiographic evaluation is very important in the first part of the phase. The second phase is when you're actually doing the surgery. You want to make sure your angulation is correct. You want to make sure that what you intended pre-op is same as intra-op during the surgery. Phase 3 will decide the prosthetic part. So when we are putting the abutment on, is it sitting in tightly? You can use a PA radiograph to see if there's any inconsistencies or if it's not completely sit down and flushed with the abutment and the implant. So, the 3 phases of radiographic evaluation. So when we look at phase 1, the primary goal is to try to quantify the quality and the amount of bone. Because when you're putting an implant into the bone, the 2 things that are key here is the quality, and which we're going to talk about later on when we're going to talk about bone physiology, and when we're talking about even anatomy. What does that quality of the bone means? But just understand the part that we're looking for the quality of the bone, and the amount of bone, which is pretty obvious because the implant has certain length and width, and you want to make sure you have enough bony structure surrounding it to be able to put the implant. The other thing is the relationship to different anatomical structures, adjacent and opposing teeth. That's very important too. We're looking at the like we talked about earlier, the infravular nerve, the lingual plate, all these anatomical structures that we're going to talk about later on during our anatomy lecture, how to be aware of it when we're placing in our implants. And these radiographs will give us a great idea of our limitation due to the anatomy of the patient. And also, there always, it happens to me so many times, where you find some type of pathology. A lot of time patients come in with PAs, you take a pan, and there's a cyst right next to the tooth or whatnot. And it gives us a good idea what the pathology of patient might be. Phase 2, this is the intraoperative part. It provides assistance in surgical placement of implant, which is key, very important. It also helps in optimal position and orientation of your implant. You can take intraoperative PA or even CT if you feel like you're very close to the nerve or the adjacent to the next tooth. And like I talked about, it's also relevant to the danger areas part of it. And you want to make sure when you're putting your healing abutment on that it's nice and placed in flush with the implant and without any movement. Phase 3 is after the implant is placed. You want to take a look at the prosthetic, make sure again it's nice and seated. You also want to look at the long-term maintenance of the implant. Crestal bone is where you get most of your resorption, because in implant, crestal bone is where is most of the stress, unlike the tooth, which has a nice PDL, and the way the cone shape of the root is help divide the forces. a lot of crustal stress is formed during implant. That's where you get your initial bone loss, especially in 1 year, about a millimeter. But you want to make sure that after a year, let's say the patient come in, or 2 year, it's not beyond a millimeter, which is expected. And if it's anything like 2, 3 millimeters, you know there's something wrong and the implant is about to fail, or it's not going to be osteointegrating. And obviously, any sign of non-integration, if you see radiolucency around it, then obviously you have to be aware of it. What are the type of imagings do we have? We in our office have obviously the cone beam CT. We also have panoramic, and we do have a PA also. But in general, these are, periapical, pan, occlusion film, Ceph, MRI, cone beam CT. These are the modalities that you can use. We can cross out, and at least, MRI. For lecture's sake, we can talk about it. But again, for implant's sake, there's really not much use, especially how expensive these are. Ceph, same thing, amount of information you're going to get versus the amount of radiation you're going to get, and the money spent would not give us much. I'll even take out occlusion. Sometimes you can take occlusion film in the mandible to be able to give you a good lingual to buccal width. But there's so much superimposed that it's really hard to tell, and so I will even cross those out to make sure that at least for implant, I feel like they're almost irrelevant. So for me, I'm just going to cross these out. So that leaves us with periapical, pan, and cone beam CT scan. And obviously, the cone beam CT scan is the most reliable, most accurate, and it's also a good teaching tool for the patient part of it. But there's a history of doing implants with periapical and panoramic. Obviously, they have their limitation, but with the right technique, you should feel very comfortable doing working with periapical and panoramic and get excellent results without compromising patient's health and success. So, one of the biggest criteria when you're looking at a radiograph, whether it be CT scan, pan, and a scan, periapical, is reliability. So if something looks in the x-ray as 10 millimeters, you want it to be exactly 10 millimeters in patient's mouth, because reliability, repeated reliability, and accuracy is the most important thing. And research has shown that for periapical, there is, and pan, and computer CTs, there's always a little bit of distortion. And that distortion is magnified. And it can affect our result. And if our margin of error in some cases is less than a millimeter or 2 millimeters, that can cause a problem. So studies shows that periapical has a mean distortion of 1.9. So you could be off by 1.9. And look at the range. The range goes from all the way from 0 to 5 millimeter. That's a lot. And that's 14% distortion. So if your implant is 10 millimeter, this distortion could be as if the implant was 11.4. So this distortion plays a key role, and we cannot assume what we see in PA to be one-on-one what's going to be in patient's mouth. Panoramic is even worse. The mean distortion is 3 millimeter. That's a pretty big margin. I mean, sometimes when you're placing an implant that's 9 millimeter, 3 millimeters is 1/3 the size of the implant. And the distortion can even go from 0.5 to 7.5. And, we have used ton of pan before we had a CT. And if you have used pan, you've seen some crazy things like these. And the distortion is about 1/4 almost. The CT, cone beam CTs are even better, but CTs are almost perfect. You have about 0.2 millimeter. The range is from 0 to 0.5, and look at the percent. I mean, that's a huge difference. Okay? So obviously the cost and everything else that comes with it, but I just want you to have an idea how the distortion is there. And it can mimic something and make you feel better as if you have so much room. but in actuality, it does not. But at the same time, let's figure out ways how we can predict these distortions and manage them and then have this type of result, close to this type of result, and feel very safe in placing implants in your office. So first we're going to talk about periapical radiograph. And in our office, our assistants are the one who usually take these x-rays. So, but just to kind of have an idea and a little recap, periapical radiograph are produced by placing the film intraorally, obviously. The film is placed parallel to the alveolus. So if you're right parallel up and down, right next to the alveolus, the central ray is perpendicular to the alveolus, thus producing a lateral image, which makes sense. And there are two, short-sightening versus elongation, and those occurs when the beam is kept perpendicular, but the object itself isn't parallel to the film. So the beam is perpendicular, the film is perpendicular, or perpendicular to the beam, but the alveolus itself is not parallel to the film. Hence, you get the foreshortening. And the other way around, if the beam is perpendicular to the object, but not the film. So the film is not perpendicular to the object, that's when you get the elongation. If you are a doctor and you're doing it yourself, you're taking the x-ray, so maybe you can foresee those two things, but you don't. We have our assistants come in, they do these things, and we have no idea which of those two happen. Right? All we know is everything was done perfect, everything was perpendicular, the film was parallel, and we see what we see. And in some offices now, obviously, we have digital versus film. There's a lot of advantage. The digital actually has 50, almost half the dosage of the film. The other obvious advantage is immediate view. No delaying, no setting in the solution. But the other cool thing is the number of shades. The contrast level is very important too, especially when you're trying to find out the bone quality, to evaluate the bone quality. And these shades, the different shades, really give us a good idea of what the bone quality is, not just black and white. And kind of a little recap, plus a little bit more addition. So what is the limitation of periapical radiographs? Obviously, due to the small size of the film, it restricts our field of view. It's difficult to interpret the anatomical details that are out of the scope. So when you have a small view, kind of have no correlation about the other teeth roots or the tooth on the top, and see the occlusion. Also, it's impossible to ensure adequate width of the bone. Same thing kind of goes with pen, obviously, because it's a 2D image. You're looking at things in 2D object. So you can see the height part of it, but you really can't tell the depth part. The depth part is missing from the PA. Orientation is difficult because your field of view is small. So if there's an edentulous area all around you, there's no reference point, so the orientation becomes confusing. And it's also hard to visualize the infraalveolar nerve, and that can go back to the part because, because of the shades of gray. When you have the infraalveolar canal running through the mandible, it's within the mandible, and it's only differentiated by the contrast level. And if your shade of gray is only 16, you might not be able to pick it up. In digital, it might be better, but still, it'll be hard to pick it up. The mental foramen, which is extremely important, especially if you're putting the implant in the premolar area, is only visible in about 50% of the patient. Okay, so that makes it also very tricky. So how do we overcome this distortion from the PA part of it? Well, one of the things you can do is you can take any known object. What we like to do is we have these 5mm steel balls. So you have a known object that's anything that you can think of. For us, it's 5mm steel ball, and you will place it at the place you're going to put the implant. And a quick and easy method for radiographic evaluation, and it'll give us a good idea and help eliminate the distortion we get from periapical pathology. So how do we compensate for it? The distortion factor at each site can be determined by dividing the actual diameter of the sphere, which in our case is 5 millimeter, by its diameter of the radiograph image. So if you have a 5 millimeter steel ball, you take your x-ray and see what the length is. If the length is 6 millimeters, then you know it's distorted by 1 millimeter. The true height of the residual ridge at the site can then be calculated on the radiograph by measuring the distance from the crest, which is the top, to the superior aspect of the mandibular canal. So let's say if you're in the mandible and you're trying to achieve the what's the distance from the crest to the mandible canal, you know, what's my limitation? You will measure the on your radiograph the crest to the superior border of the mandibular canal and multiply by this result, which is the distortion factor, and that's what the distortion factor would be right here. And I'll show you how to calculate that in a second. So here's an example. So, you know, we're looking at, let's say, the floor of the sinus right here. You know, you don't know what your distortion is. We have our tooth right next to it. So what we'll do is we'll take the known length, which is the steel ball right here. So let's assume it's 5 millimeter. So we'll take 5 and we'll divide it by the measured length on the radiograph. So we'll take the 5 and then I'll take my probe or ruler and I'll measure the diameter over here. Let's say it's 6. So if you take 5, you divide it by 6, that will give you your distortion figure. Once you have your distortion figure, then you're going to multiply that by the actual length that you measured in the radiograph. So let's say if you measured this 10 and your distortion was 0.8, so it'll be 10 times 0.8 will be your actual length of the bone. That's a pretty good tool to have, and it'll give you great predictability to be able to measure how much bone do you have with PA and take one of the big limitations of PA, which is distortion, and make it a very safe method of evaluation. And in this case, we have a clear, we made a, let's kind of show you, I'm sorry. We made a clear, this is, you know, what I use. I use a clear and then put my metal and kind of glue it in the area so you can kind of see it within the field of view and we can measure it out. So, and it's a great tool also, you know, if you're not really using it for PA for measuring length, but you know, and if distortion is such a big part, you're worried about it, at least PA is very good during the or intraoperatively when you're just looking at the alignment and the angulation. Those are less affected by distortion, so you can have a really good idea with angulation at least when you're taking the PA if it's really angling away from the adjacent tooth or right down the middle. And also for recall, you know, just to see if there's how much bone loss at the crustal or if there's any radiolucency around the implant itself. So, you know, if you have a CT scan or not, and you have a PA, it still has a value of its own, and then our indication would be for those purposes. But with the method we talk about, how to compensate for the distortion, if you use this formula and have a known object, you can also get a very good result regarding the space. Now, panoramic is probably the most used radiographic modality for dental implants, and like we talked about, it almost had 24% distortion. Not just that, the distortion is not same throughout the whole panoramic. So this 5 millimeter ball, for example, had a distortion of 16, 23, 25, 29, 29, 26, 16, 16. Same view. So if you're putting implants in, just because you know you did your steel ball in one area doesn't mean it will correlate to the other side. Or if you're doing it on the back, doesn't mean it's the same as you're doing it in the premandible or the interior of the mandible area. And part of the reason why, because it's a curved plane, pan is the your mandible is the curved plane tomographic radiograph technique. So it literally takes a curved plane and makes it flat. So your distortion is like that too. It's kind of like kind of like how Earth maps are done. So it's like it's kind of like you see a map of the Earth, and the Earth is round, but the map is flat, and it distorts the image. So the flat map really is not one-to-one representative of exactly how the globe is, where the continents sometimes look their stretch. Um, if you look at the map, flat map, the Africa, for example, looks smaller than Europe, but in actuality, that's not the case. And the only true way to look at those proportions is actually look at the round globes that we have instead of the flat map. And same thing here, where the mandible is curved, and you have the tomographic radiograph technique, which makes it flat in 2D. So that's why that distortion is throughout the map, and it's not consistent. From one side to the other. So how do we overcome this? And it's basically the same technique we use for our PA, but in this case, you have to use one for each spot. So, and we use the same technique. We know the known length ball. We divide it by the length measured in the radiograph, and that's our distortion figure for that particular area. So unlike PA, for PAN, you'll have distortion figure for each individual areas that you're trying to put the implant in. And then you take that distortion figure, you measure it by the length that you actually observed in the radiograph. For example, if you feel like, let's say we're thinking this is the nerve. It's not, but just for the example, let's say this is a nerve. So you'll measure this distance and then times it by distortion. That will give you the actual length of the bone from here to here. All right. So we already talked a little bit about one of the main disadvantage of PA and PAN because of their 2D nature. What are the advantage of PAN? Well, it's helpful when planning multiple implant sites because you have complete view in a single shot and you have a big nice picture. It's also sometimes is good for proper positioning. Like I said, right around the canine, it becomes really tricky because, again, that's the curvature part of your mandible, which is not going to be tomographically flat on the pan. And one of the biggest advantage by far is a wide field of view. Good way to find pathology, especially if they have wisdom teeth or cysts associated. And you can kind of make comparison to the contralateral landmarks, use them as a guide and be able to kind of see what's going on. TMJ, when we're gonna talk about later in occlusion, is very important. And you'll give, it's not a great module for the TMJ, but again, it gives us some very basic, if there's a big, some certain pathology, if the joint is not within the fossa itself. And using the distortion technique we talked about, it can be a good predictable of the vertical height. The width, obviously, you can't, not width, the depth, I'm sorry, from palatal to buccal or lingual to buccal, it's tough, or not just tough, it's impossible, but the vertical height can be predicted using that technique we talked about. The disadvantage of panoramic radiograph, it's loose anatomical resolution, so it's hard to find that mandibular canal, probably because the lack of limitation of the gray shades. There's no information about the thickness of the bone, just like the PA. A lot of superimposition and overlapping of structures which distort, and I'll talk that in about a second. Well, let's just do it right now. So, for example, this is the floor of the sinus. And and when we're going to take a CT, we'll look at this floor of the sinus and see it's not uniform like that. There's almost like a cup that goes in there. And this line really, we don't know what exactly it represents. Within that cup of the sinus itself, it could be the top part or the bottom part. The other disadvantage we talked about was there is no uniform magnification, so each area has own distortion throughout the pan, and you have to really tackle each case individually, and there's no one number that kind of helps you go through the whole thing. Patient position can cause extreme errors, and again, since we're not the one who taking these X-rays is, we can't predict what we did and what kind of errors we might have. The vertical distortion deceptive by the depends by the distance from the patient and the arch of the film. So again, this comes down back to the patient positioning. The horizontal distortion depends on the object film distance. So, if you are seeing consistent error in these two, maybe you can go back and you say, hey, my distortion numbers are way off in here and that, or when I measure this number is coming consistently being off, maybe one of these are the issues that might be. Even the repeated pantographic has huge distortion with them. So if you're trying to use pan, you have to use the formula we talked about to have good prediction and reliable result. These distortions make the assessment and determination of implant length basically extremely difficult. I mean, that's the general idea. But if you use the technique we talked about, you can have very predictable result. So let's talk about the cone beam CT scan. Currently, it's the most useful and the precise radiographic modality for treatment planning in oral implantology. Understand the difference between the medical CT and cone beam CT for dental implantology. Those are, there's a big difference between those two, the amount of radiation, even the accuracy. So we obviously have cone beam CT, and initially we talked about that is about 15,000 radiation dose versus only 100 for the cone beam CT. So there's a big difference for it. And if you do want to send your patients out, make sure they're getting the cone beam CT done and it's relevant to you. So what's the advantage of CT? Immediate result, high detail. Some of these images can be reconstructed in a 3D model, and I'll show you guys an example of this. No superimposition, no overlapping, no distortion. You get the bone height and the width and the quality of the bone. And if you remember, one of the advantages we're looking for, or the key thing we can get out of radiograph, is bone quality and bone length. So it also gives you all of the above. And it also gives us the thickness of the cortical plate, which is also very important if you're doing some of those teeth in a day or teeth express or all on for any of those techniques. And you're looking for that cortical bone and primary stability. So continuing with the advantage of CT, precise location of the mandibular canal. So not just that you can have a good visual, but you have exact precise location of the mandibular canal. The maxillary sinus and its floor, the nasal cavity, the mental foramen, the incisive canal, the nasopalatine canal can be located. The ridge, the trajectory, the angulation, because now you're looking at it in a 3D image. You're not just seeing one side that's the highest, but also maybe let's say the buccal side is nice and up, but the resorption is on the lingual side. On the PA you can't tell, but in CT you'll be able to see that. Submandibular fossa, when we're going to talk about the anatomy portion, I'm going to take the CT scan and anatomy and kind of show you why that's more important, but at least right now, just a starting point, it helps figure out the depth of the submandibular fossa. Any surprises within the ridge? We see that all the time. Elimination of guesswork, that's very important too, because when you go in, and I'll give you an example of when we did initially when we used to do with our pan and PA, I used to have 3 or 4 implants in my hand. The length I was pretty sure because we used our distortion technique, but the width was usually a challenge. But once with the CT, you just pick exactly that one implant. There's no surprises when you are actually doing the surgery. And that's very important. If you do the treatment planning correctly, the whole idea is to make the surgery fun and safe. And those two happen when what you do is very predictable. So what you see during the surgery is exactly what you expected. And that's the goal of pre-op workup and radiographic information. So no welcome surprise like I talk about on the day of surgery. That's important. So let's talk about, when we talk about CT, the goal is to educate you how to read a CT, how to manipulate it, and use it to your advantage when you're looking at for implant. Okay, so the basic thing you have to first understand is views. What angles do the most CTs come in? One is the sagittal, and you can see if this is a person, you take that one plane size right down the middle. That's called the sagittal view. So it looks like almost like the half cut out. So each plane, if you go 1, 2, 3, 4, 5, 6, will represent this on each side, right or left you're going. So that's the sagittal view, right down the middle. The coronal view is you're looking at the patient's face and you're taking each slice. So each slice going from the front to the back. So the sagittal one was going right to the left, right down the middle. You can see it. That's the teeth. You can see the lip and the chin because that slice is right down the middle, and it'll go right and left to the patient. The coronal is right down. You're looking at the patient's face, and each slice, one of these slices, is going to go either anteriorly or posteriorly. So you can see the width here nicely. So this is one slice right here where the patient is, and either it's going to come forward towards you or it's going to go away from you. Okay, so if it's coming forward to you, it'll go from the second molar to the first molar to the canine, and if it's going back, it'll go the other way back. The axial view is when you're looking from top to bottom. So this is a plane. Either the plane will go to the top or to the bottom. So here, which is here and representing here, that's the nose, that's the maxillary sinuses, that's his ear, that's his cavity, cranial cavity. So either it will come up towards his eyes, or it's going to go towards his chin with the same plane, that nice horizontal plane right there. Okay, so these three views are very important: sagittal, coronal, and axial. So each kind of play a little role in implant planning. So what I'm going to do now is pull up a CT. So here's a CT of we have a young patient here, and you can see the 3D reconstruction that can be made. So it kind of gives us a nice view, and not just for yourself. I mean, imagine showing this to your patient. They get the ooh and the ahs out of it, but it's also kind of helpful for us for seeing occlusion relationship and any pathology, or actually. But here's a pan part of it. But the limitation for the pan would be, you have an idea there's an infraavicular nerve around here, but kind of have no idea what his relationship to the roots would be, right? And it's hard to pick out where the mental foramen would be in this case. So you can already see the limitation. And on the bottom, obviously, I have the CT scan cuts, and I'll go through this. So this is the axial view, okay? So this is the view if you're looking from the top, and we're going to go slowly down, and it's in the horizontal plane. Okay, so I'll just kind of pull up the PowerPoint. So this is the axial view, right? That would represent right here, and you can see this is the cut on this a horizontal cut, and so either we can go up or bottom, and you can see it over here. So what is this view for? So if you're looking at this view, you can have a good idea of the ridge, how wide the ridge is. Okay, and let's kind of go up and down, and you can see nicely that's the palate. We're going all the way to the nose, and obviously this is correlated. So what are these images? So you see these three lines up here. The middle line would be right here. That's a box that represents that middle line right here, and each line right next to it would be around here, right and left. So you have a good idea in this area what we're looking at down up here. And this line up here is where this slice is. Okay, so this slice right here would be this one right here, that horizontal plane. Okay, so when we go up, this slice will go up, and it'll go toward the bottom. So in this case, we're right at the floor of the nose and the nasal cavity. You can see the turbinates right here, the maxillary sinus, and it looks like it has a septa, right? The extra bony game will go over that in our anatomy lecture. So that's the axial view. This right here is the sagittal view. So let's bring our line down. See how it's coming down? Okay. So this is a sagittal view. So let me pull up a sagittal view. There it is. Small it down so we can see it. All right, so you can see this is a sagittal view. Okay, so right down the middle, there's a slice, and we're right down the middle around the canine area slice. Now, this is for us, this is one of the more important thing because it gives us the width, the height, and the relationship with the opposing tooth. And you can see this is the lip of the patient, so a little bit of soft tissue help also when we're talking about lip support and draping. And for implant part of it, those two are very important, obviously. The height and the width can easily be seen over here. And here it's obviously this is not good um, from the distance, let's say from here to here. Can't see that from here, obviously, so you kind of have to rely on this picture for that part. But when it comes to the height and the width, the sagittal is probably the best view. Uh, so we talked about um, the axial view, the sagittal view, and what they each represent. So let's kind of go left to right, okay, and see how the sagittal view comes up. So, the way the cone beam CTs are, it's literally middle cuts right down the middle, right? So when you're going to the back in the molar, this is pretty much like the coronal view. Okay, so it's not truly a sagittal view. It just gives you the cross section of the area. So it could be sagittal from canine to canine, but behind the canine becomes almost the coronal part. And if you remember the coronal, it's basically going from the front of the face to the back straight down. So this nice little, it's like you're peeking outside the window, and when you're peeking outside the window, each layer that goes through the window is represented over here, and you can see the cross section here. And it'll be good in looking at the mandibular, submandibular fossa that would be here. So it's a good way to figure out, you're looking from the top, you don't have a CT, you look it from the top, you're like, oh, sweet, I got 14 millimeter of width. I mean, you can do anything you want, but in reality, for most of it or a lot of it is not supported. So basically, in reality, you only have about 9 millimeter of space. So what are the tools that we have to measure it? If you right click it, we're going to talk about the Hounsfield unit. Distance, obviously, you click on the distance, and then whatever you want to measure, for example, how much cortical bone you have. From here, you drag your cursor, and it'll give you a good number, 4.54. And as we talked about, the distortion in CT scan is from 0 to 1.5. So it's extremely reliable and predictable, and you can find anything you want. You can even look at the cusp relationship, for the occlusion part and how to angle your implants. You can even magnify it. So if you go around the screen, see how there's an X, the cross means I can move it around. And if you walk around the screen here, you can change the contrast if you want. If something, you're like, what is that little part? So remember we talked about the advantage of film versus PA, 256 colors versus 16. The CT has even more. You can actually manually create that contrast to see the difference between the two objects. Magnification. Okay, so you can manipulate stuff. So those are the tools that you have on the screen by just looking at the cursor, how it changes as you walk around. You can even set up filters, sharp. Again, try to create the contrast. You can even break the images down. Some people like 7 out of 3, so that you can see all their span of it, multiple images part of it. I like the 3x1, because it gives me a nice big picture of what I'm looking at. All right. Obviously, one of the biggest advantages, you can actually estimate the nerve canal. So let's do that. You right click it, and go down, and it'll say estimate nerve canal. And the way we estimate is you first find out, let me get rid of it. Okay, where the mental foramen are. So we'll use the axial view, and we're going to go down, down, down. You can see this is the layer that we're on right now, and how we're going down, down, down. And then you're going to actually see the mental foramen. There you go, on the right side, and we'll click it with the right button. Find on the left side, click it with the right button, and then we'll find the mandibular foramen. So we found the mental foramen, where the nerve exits. Now let's find out the mandibular foramen, which will be on the medial side. Let's do the right first. There it is, right? You can see that opening right here of the mandible. We'll right click here, and then let's find out, and there, right here it opens. We'll right click there, and then we'll do both canal. Obviously it's an estimation, but it'll give us a good idea on the path. So let me confirm it now. So not just that you can see the nerve on the 2D image like you would pan, so it actually shows it to you in of the nice path of the infraavular nerve, but within this cross section of it, or in this case coronal, you can see exactly within the cross section where the nerve is, and that actually plays a pretty important role. You know, in some cases, if let's say the nerve is over here and you have a tapered implant, maybe if you place your implant a little bit to the left and angle it, you'll be able to have more room and avoid the nerve. I mean, I don't recommend you guys trying this, especially if you're doing it for your first time, but just kind of give you an idea what in the hand of a surgeon who's done a lot of implant, what a great tool this could be. That not just you can see the path of the nerve, but it can also give you the orientation if it's buccal, lingual, or in the middle. And let's start out with the path. So you can see here's the mandibular foramen, the nerve is in there, and look how it's traveling down, right down the middle, and then slowly go from the lingual, and it'll go to the buccal, and exit the foramen right there. See how it's exiting? And you can see the path right here. And remember, we talked about this line represent here, the other two boxes are here. So not that you just get the one-on-one relationship, but you can also get the exact path and orientation of the nerve as it crosses the mandible from the foramen to the foramen. Now, since we went over the CT scan, talked about different tools to use for evaluation, magnification, changing of the contrast, we also learned how to path the infraavular nerve, and just the concept of how the layers work, how to see the cross section. The other big important part, and it goes back to our first slide, we talked about the type of bone, right? We know the length with all the tools we talk about, the width, but what about the type of bone? How can CT help us with the type of bone? And I'll go in much more detail when we talk about bone physiology. But I'm going to show you the tool that we use and a little bit of understanding of how it works with a CT scan. So we're going to talk about the Hounsfield unit. This is what we use. Again, it's a relative term, the number, but again, it'll give us a good idea, again, to be able to predict what's going to happen on the day of surgery, and that's the goal. That's all we're looking for from radiographs, is to give us as much information so the case when I'm actually doing is predictable, and what is there is what I already know and what I'm already expecting, so I'm prepared for it. So by definition, the CT scanners that are calibrated with the reference to water. Okay, so this number is in the CT scan. They calibrate the CT scan with water on it. So they basically place water in the middle of the CT scan and calibrate that number and use that number, and based on that number, everything is referenced. Okay, so for example, compared to the water, if let's say water is 0, the bone is considered to be 1,000. On average, you'll get 1,000 number of bone. And again, this is not the quality of bone. I'm just giving an example in a macro level, not in micro. The bone would be 1,000. So like I said, water is 0. So if water is 0, bone is 1,000, liver would be between 40 to 60. Uh, the muscle is about 10, kidneys is about 30, CSF, which is fluid, is about 15. Sometimes the number can even be negative compared to water because, again, water has some type of consistency versus versus air, for example, which is like minus 1,000. So it's a relative number. Depending on the coefficient that are variables. So the key part is it depends on the variable of each machine and how it's calibrated. So the number is relative within the CT scan itself, and that's how I like to use it. So, in your CT scan, you have your own ratios and your own machine calibrated, but at least we know the reference number would be 0 for water, and then from there on in. And I look at more at the ratio, versus a cortical, air, sinus, and they'll give you a good idea. So when we talk about the quality of bone, so let's have this what we call bone density, and there are 4 types, and this is a MISH classification, which I will again go back in much more detail when we talk about bone physiology. But again, here I'm gonna try to correlate how the more denser, obviously, the higher the number. 0 means water, so the lower the number, the less denser the bone. So that's the quality of the bone that we can use the Hounsfield unit to be able to do it. So let's see how we can use the Hounsfield unit to look at the quality of bone. So as we have a general idea, the interior of the mandible is usually very hard and it's very cortical, and the softer the mandible in the back. Just to kind of have an idea how this works is, let's look at our Hounsfield unit. So this is the HU. You do a left click on it, and then you get this, and you press your left, and it'll make it a little bigger. So that'll become your the mapping site that you want to check the density of, and then you can use it up and down. Here is air, right? We're in maxillary sinus, it's air. Look at the number up here on the top right end. The mean is about 768 minus 800 minus 830, okay? So relative to water, which is 0, air is minus 796. Let's look at the soft tissue. So this is more like blood and soft tissue part of it component. That's minus 282. So makes sense. It's almost you're looking at the ratio of from minus 700 to 600 to minus 300. Now let's find something that would be next, a little bit more denser. So we're looking in the maxilla, in the premolar area, the bone right here. Now you're in the positive, 13, 18. 16 as we're moving along. So this is the quality of bone, the maxilla. We know maxilla is soft, but still compared to the soft tissue, which is minus 300, you're at the 100, 200 range, or let's get it up here. Let's 100. Pardon. And let's look at the cortical bone. Look at the cortical bone, 650, 639. And the trabecular bone in the middle is about 200, 300, and even the cortical bone changes as you move along. It could be more porous in the maxilla versus the mandible, and even contrast can give you an idea. But it's a good way. So if you have more of this cortical bone, it can tell you it's a denser bone. That's the quality of the bone. It's a denser quality of bone. Versus if you're going back, let's say we go back almost to the tuberosity area. Let's see if I can find it right there. Have a HU. Let's measure the bone here. Look at that. It's about 200 versus, remember we were talking about 600. But look at this soft trabecular bone. It's almost in negative 200 now. Little bone here, 20. Trabecular bone is 20. 100 trabecular bone. And the enamel itself, look at it, 400, 700, which was expected because it's much more dense. So this is how we use the Hounsfield unit. Look at the cortical bone here. Let's measure that also. About 400, 500, 300, 400, 500. Let's see, mean average 500, and compared to the interior of the mandible, the thickness is about the same, but here's about 400 or 500, and over there is almost 500 to 600. So you can see even within the cortical bone, even though you can take an x-ray and you can see, hey, I have about, measure the distance, about 5.47 of great cortical bone, but it's great. Even the strength is pretty good, but the quality is different from of the interior of the mandible. So just to a quick review about the CT scan, we talked about different views: the axial view, uh, the cross section, which could be either coronal or sagittal. We talked about how to not just predict the nerve, but see the path of the nerve from 3D point of view as it crosses from the lingual to the buccal. We're talking about the Hounsfield unit to be able to predict the quality of the bone, not just the height and the width. And obviously, one of the biggest advantage that you have is there's absolutely no distortion whatsoever. You can change the contrast as we talked about. You know, if you want to see different color situation to find difference between two objects and their contrast, if they're same or not. Magnification, you can magnify it and move it around. And we also talked about, it sounds, as if there doesn't mean anything, but the wow factor when you're showing your patient around with the 3D image. And all of this with the cost of about 90 to 50 micro radiation units that we talked about. So it's safe, it gives us high predictability, it gives us a good manipulation so we can actually treatment plan it and avoid the structure part of it. And like I said, it's safer. The cost of the CT scan becomes an issue. And in the market, it can range. If you're looking from a small view, you can even buy a used one from 50 to 60,000. But a full view of the maxillofacial could run from 100 to 150, in some cases even 200. You can even send it out. The price of getting a CT scan done on the outside can range from about 250 to 400 to 500 bucks, depending if they want to do reconstituted in a 3D format or not. So and that could be incorporated in part of patients' implant costs, and you can let them know, hey, I can show you. So it'll be well worth them. If you actually show them their own CT scan and show them what you're doing, it'll be worth it for them, and maybe even worth it if they want to get implants later on. And especially if you're doing a multi-implant case, that 250, 300 cost is so well worth it. But regardless, if you don't have a CT scan around you, we talked about using PA and PAN and the distortion number, how to manipulate that number by using fixed objects to calculate it and make that very predictable also. The other thing we can use is we can also use soft tissue mapping. And with that, because remember we talked about where the one of the weakness of periapical and PAN is, we can use the distortion formula we talked about to get a good height, but it still lacks in the width part. And for CT scan, for example, you can see a nice width, right? And how would you compensate this for PAN when you don't have the ability to measure the thickness, not knowing what the soft tissue is and where the depression comes from? So one of the things that I like to use is we like to use a probe, and we like to put a little like endodontics, endo plunger on it, and you can see the plunger, and then you map it up and down, and then you can actually measure original distance that you have from tissue to tissue and subtract the number once you pierce it through. You take that number, measure it down, and kind of subtract it, and then literally map it down. So from this area, if the cross section, for example, from here to here, I measured 9 millimeters. I'm just hypothetically making a number up, 9 millimeter, and I'll place these dots in. I'll put one dot in, let's say right here. You can see on the stand. I'll subtract, and you place that dot in, and then you measure it. Let's say it's about 4 millimeters. So out of that 9, we'll subtract 4, and the other dot is going to be exactly on the other side on your stent. So what you're going to do is you minus 4 here, you minus 4 here, and then you will know that, hey, or minus 2 here, your actually number is going to be subtraction from the lingual to the buccal. So you take the let me recap it again. So you take the total number from here to here, from dot to dot that you measure on the top, and then you subtract after you placing the probe in on the buccal to the lingual. So if your total number from dot to dot, let's say it was 9, and you measured here and it was, let's say, 2, so, and you measured here and it was 2, so it'll be 9 minus 2 minus 2. So again, a little bit more work, but at least if you understand, and this is a nice technique to be able to find the width. We use the height with a PA, and then you do a clinical exam and make a nice stent that's hugging the tissue, measure the distance, and then at each area, so you measure the distance, let's say from here, from this dot to this dot as your whole number, and then you subtract it when you place it in. So you'll know exactly what the tissue height is on each side. All right. So this will conclude our radiographic evaluation. We discuss the phases, how radiograph is used in 3 phases in implantology. We talked about the radiation aspect, how much each radiation is for periapical, for PA, for CT scan, and how it's compared to other modalities in medicine for radiation dosage. We talked about different ways, for example, the periapical, CT, and PAN, and each has its own advantage and disadvantages. And one of the biggest disadvantages we talked about was distortion. And we talked about how using FIS object to help us negate that disadvantage. We also talked about this technique right here to have an idea what the width is by using tissue mapping. And then we talked about the CT scan. We talked about multiple advantages of CT scan, including no distortion, ability to map the infraalveolar nerve, the Heinzfeld unit to have the quality of the bone, magnification, the height and the width, structure, your key structures, and also the wow factor for the patient. We talk about a little bit about how much they cost, if you have your own CT or if you want to send it out, and how you can have this within the part of your package of doing an implant dentistry. Okay, so as we go on, we'll use these CT scan to kind of go over a lot of different aspects in implant dentistry with anatomy, surgical technique, and even occlusion sometimes. So these rules are going to come up over and over again. And the key thing I wanted you to get out of it, beside the basic information, is just try to understand the CT scan. So now, when we're going to talk about CT scan, and I'll bring this picture up again, I don't want you to be, deer in a headlight. I want you to understand what this is in a regular pan, because you're so used to seeing this. You should know that this line right here would be a slice right here, and this would be the cross section, this will be the height, okay? And you'll know what this is. This is the axial view from down up, right? So this is the coronal part of the teeth, and we're slowly going down. All right, so this concludes our radiographic evaluation. Thank you.